Thanks, George. Appreciate the opportunity to speak to you. I'm going to talk to you about our experience with our ACO in Iowa. Let me give you a little more of my background. I'm a family physician and started doing a lot of this work just in my own practice back in the early 90s. And then started doing quality work for my organization and then became the president of the physician group. Then in 2012, I became the leader of the accountable care organization, actually formed the accountable care organization for our parent company. So I'm going to talk to you about largely about our IT efforts, and I think we developed a unique IT solution to doing our value-based care. I'm going to share that with you and how we developed the IT solution for our needs of the population health. Talk about our care management practices and what we're working on to reduce the cost of care in our populations. So just give you a little background about our organization. So Mercy ACO is owned by Mercy Health Network. Mercy Health Network is really an organization of the Catholic hospitals in the state of Iowa. So we have 6 urban markets, and we also manage 30 small critical access hospitals on top of the 6 urban markets. Mercy Health Network is jointly owned, half owned by Catholic Health Initiatives out of Denver, and the other half by Trinity Health, Livonia, Michigan. So 2 of the largest health systems in the country really are our parents, and we interact frequently with them and their staffs on our work we're doing. So we have 6 chapters. We operate in 2/3 of Iowa's counties. We have 20 value-based contracts, and in those contracts we cover over 300,000 lives at this time. So among those contracts we have 4 Medicare shared savings programs. So we have a Track 3 MSSP with upside-downside risk and meets APM status. We have a Track 1 Plus MSSP, again, upside-downside risk, and is qualify as will qualify as an APM. Our Track 3 has qualified as an APM. And then we have 2 Track 2s. We have 2 Track 1s. We have a Track 1 rural site, rural ACO for rural, and a Track 1 urban ACO. The urban ACO for the urban sites that aren't quite ready and developed enough to take downside risk, so we put them there. And then we learned the hard way that Medicare shared savings, at least in Iowa, just plain doesn't work in our critical access hospitals with their cost plus reimbursement mechanism. And so it took us 2 years to get them out of our ACOs and now financially doing better on the MSSP, but that did not work out very well for us to have critical access rural hospitals in with our urban hospitals. We have multiple other contracts. We have a large commercial contract that covers the state. That we have 2 Medicare Advantage contracts that have shared savings component to it. There's a medical loss ratio component to those, and if we beat that, we get the savings for those. And then we have Medicaid contracts, and there's 2 large Medicaid managed care organizations covering all the Medicaid in the state of Iowa. We have employees and contracts to about 20,000 lives worth of that. So those are our contracts that we have. We have almost 200 participant organizations in our ACO now, and over 3,000 providers who are participating in that. So our organization for the ACO, we have 30 staff in our central office. And so this is me and my chief operating officer, my quality officers. I have a staff of 9 analysts doing our IT analytics. We have compliance people, credentialing, and CDI staff, clinical documentation improvement, to capture our risk scores and get the risk scores up for our population. That's our organization in Iowa. If there's any questions, I'm glad to take questions as I'm going and modify what I'm going to talk to you about. Here's our results since our inception. So these are our results year by year. We lost money in our first and our third years, made money in our other 4 years, and to date we've returned over $12 million in excess of our expenses back to our participants. So we've had success thus far. Talked about our background and how we learned to do this and how we got into the population health and the value-based type stuff. And as I mentioned, it really started in my own practice back in the mid-90s when I started tracking all my patients with diabetes and high blood pressure in an Excel database. And so what happened is I knew who all my patients were who had diabetes, and I would and I knew whether they're meeting their goals or not. So I would call people up who weren't meeting, or who haven't been in the last year. I was amazed that 70% of my patients have been in, 30% had not been in within the last year. I swore they had been in, they were my patients. I call them up and ask them, how come you haven't been in? They say, well, no one told me. You can imagine you got a doctor who's compulsive enough that he's tracking every one of his patients in the registry. I told them, but that's a real lesson, because patients don't hear what you think you're telling them, and that's something we really had to learn. How do you communicate with patients in a way that they do hear it and understand it the way you hope they would? The other thing we learned from that is that, I learned that when I called them up and asked them to come in, I'd get almost all of them to come in. I'd get 97% to come in for 1 year when I proactively worked my population instead of just waiting for them to come in, which was 70%. The other thing that surprised me was how poorly I was in my results, and what poor percentage I had who were controlled in their blood sugar and in their blood pressure results. But I also learned that when you systematically work those populations and get those people in, you do remarkably better in the percentage that are controlled. And that's really been the key to our success in our ACO, as we've been able to extend those same lessons from one practice now to 25,000 diabetes patients and 60,000 hypertension patients. And we're doing the same thing, and when you do that, you save about 3% is what we've learned from doing those two tricks right there. They're just tracking the registry and don't lose them to follow-up. So we learned from a very small registry, started expanding and getting bigger registries. I was able to go to our hospital lab and said, can I get data dumps of all your hemoglobin A1C and LDLs? And they said, oh, sure. And every month they'd give me a data dump of everything that was done that month. I put it in an SQL database and started tracking all that. And mind you, this was in the 90s, well before HIPAA. And in my son's bedroom, we had data on tens of thousands of patients. And luckily enough, we never lost any of that. But back in the 90s, that was okay to do, and no one was concerned about it. We couldn't do that anymore. I started creating reports for all the doctors in our organization. So not only was they doing my reports now, I was giving reports to every doctor in our organization, about 100 primary care doctors, saying, here's your data. And the first thing they always said, I know they can't be right, I know I do better than that. The data's wrong, I know I'm better. We finally convinced them that they weren't, and started working with them. And lo and behold, our scores got better and better on controlled blood pressure, control of diabetes. When you had all the data, you could go out and start asking for grants, because the grantees were very impressed by someone who had data. Not many people had data, so grants were not that hard to get, and we started looking for staff who could manage the data for us, because I thought early on, this data is not a doctor job. Doctors aren't supposed to be working this data on calling people in. So we started, we got a grant to hire our first 4 health coaches. That actually didn't work, because we only had them half-time, and they always got pulled for other stuff. Second grant, we got 4 more full-paid, full-time coaches, and they started managing the data that we had in our databases for us. And what we started doing is calling up people who are overdue for care and not meeting their goals. What we learned very quickly is that almost everyone we called had been in the office while they were overdue for care, and they didn't get the care done while they were in the office. And so we started taking our coaches and doing this pre-visit review. So every time before people were seen in the office, we reviewed their chart, and we had standing orders. We got all the doctors to sign standing orders. That was a whole task in itself to get them to agree on standing orders, but we got it done. And then we would do all their needed tests for blood pressure, for diabetes, preventive care by standing orders and get it done. What we found then that these coaches were then generating over $600,000 of revenue a year for every time we put a coach in an office. So needless to say, we soon had coaches in every one of our offices. And this was back in the early 2000s that we had that done by. Up to this point, we were using free databases. We were doing manual data entry for all of our patients. But we were making so much money on the enhanced revenue side that we could afford to hire people to put this data in. Then in 2012, we finally got we thought, oh, we're really getting on top of things now. We got to register. We're going to get automatic data feeds for electronic medical records and put the claims data in this thing and get our billing data in there. And so we hired a company, and we never really got the data into the system. You know, they had great analytics. We said, look what you can do. We got all excited about all this. But getting the data from these disparate sources into one database is a very difficult thing. And I think that's the key thing that you need to learn to do is get the data from all the sources into one database. So you're not looking all over the place to get your answers for things. So that led us to our relationship with Innovaccer. And how do we end up with them? Well, like I said, we got a lot of grants. We got a CMMI grant to take our infrastructure that we had already built and move it into our rural sites. So we had money for rural sites. We couldn't get the rural data in. So we hired this small company, Innovaccer, who had never done a data warehouse for an ACO, and asked them to get the data from our rural sites and bring it into our database, our Medicare database, McKesson database that we had. They did it in 3 months' time. And so McKesson didn't get it done in over a year. I hope there's no McKesson people here, but it was over a year. They didn't get it done. This Innovaccer company came in, gets it done in 3 months, and they did it for half the price. So we were pretty impressed. And then they came to me and said, well, you know, all that data we've gotten put into your database you have, we built a replica database for you. And so we have all that data in a replica, and we can put a front end on it if you like. So we thought, that sounds pretty good. So we started talking with them. We developed a contract with them. So that was fall of 2015 when they got all our data for us. And then by the spring of 2016, we convinced our board to sign a contract with them and let them take over all of our data needs. So they started putting grabbing our data from our urban sources instead of just our rural sources, and putting a front end on this database. And it was nice because they designed the front end to our specifications and put what we wanted into the system. So so that was in the spring. It took about 6 months to get something that was actually live and working for us. And that was the fall of 2016. By the spring of 2017, we started developing care management. So we built our care management infrastructure and software for tracking our care management interventions into the same database. So we could use the data in the database to feed our care management activities. We'll show you how we automatically feed those care management activities. So that was spring, fall. Our big thing right now, the fall, this winter, is getting our last data sources in. Our biggest problem with data sources are our parent companies. I mentioned we have Catholic Health Initiatives on one hand, Trinity Health on the other hand. They have these large medical records that they installed across the nation in our markets. And it's very difficult to take one market's data out of these systems. They have all these different markets across the nation into one database. So they can't give us access to the database because of privacy issues. We can only see our data. We can't see anyone else's data. And they can't get it out in an easy way. They built us replica databases with just our data and said, here, you can have these. But it just never seemed to work. There's always a table missing of something we didn't understand. And then you go to like we have Allscripts in one of these markets, you go to Allscripts and say, they had no standard nomenclature. So they didn't use LOIN codes for their labs, and they couldn't pull the stuff out that you needed. And they said, we'll explain it all to you, but it'll be $500,000. So we haven't done that. We're trying to figure it out on our own. struggling through. Getting the data out of our own electronic medical records is our most difficult. Getting data out of a small electronic medical record that we have in a critical access hospital, no problem, get that data out. But you think that big sophisticated organizations can get it out, but they built their systems too complicated for us to easily get the data out. And really all the privacy issues, data governance issues, you got all these data boards and things to get through we're working through all that stuff. So anyhow, that's where we are now. We're getting the last bits of our data. We're getting our electronic medical record data in there. And we got most of it in now, but not all. So that's our background in getting here. So we're doing this. What do we need to do? What do we need to design this system for? So these are the things that we needed data for. So the first thing we need to get the data aggregated in one spot. So you take data from multiple sources and you aggregate. So you have to match a patient from the lab data to the billing data, so you know it's the same patient. So you go through all these matching algorithms and learn how to do that kind of stuff. Then you need to normalize the data because I think the A1C value in one place might be recorded a little bit differently than one in another place. So you have to make sure that the values matched up from place to place too. So that's what I mean by aggregation and normalization. And I maintain if you're getting a data partner, this is the skill you want. Everything else is easy compared to this. The analytics that looks so fancy, that's not the hard part. We need metrics and performance measurements. We need to measure ourselves, so we know if we're improving or not. We built our care management system right into this with the care management workflow all hardwired, so we know it's being done the same across the state. I think I mentioned we have 106 RN, health coaches across the state of Iowa doing all of our care management work now. So we need to make sure that they're doing the right work and that we know what they're doing. And so we built it in the system where they got to follow a certain pathway, and we can track and know exactly what they did. We do ad hoc reports, the security, privacy, data segmentation. We set this thing up so we didn't run into the issue that our parents did, so that we could give one market all their data very easily and give another market their data, and they weren't mixed. We've been working on analytics, and our big thing we just signed a contract for is the interoperability, so we have two-way communication between our electronic medical records and our data system, and that is just getting started. So first, data aggregation, normalization, probably said what I had to say about this, but you're taking the data from multiple sources, electronic medical records, payer claims, the physicians' billing systems. When they create their bills to send them to the clearinghouse, to send to insurance companies, we just take a copy of it at that time. So we get it, we get that in real time. We have a public source. We have an IHAN, the Iowa Health Information Network, where people are putting data in the state of Iowa, and we pull that data out. So we match the patients, so of all those things, we match the patients across that, and then we start putting out our reports, our metric reports that I'll show you about. So the scope of our data collection, we have nearly 200 sites across the state of Iowa, and each of those sites have about 4 data sources that we're incorporating into this. And if you think, you have a Cerner installation at 10 sites, and so, that's good. You do your interfaces for Cerner, and you have that done for 10. No, you have it done for 1. So every single site is a separate data pull, and what you learn from one hardly helps you with the next. It doesn't matter. That's the same name on the company that you're pulling from. So we have a lot of experience aggregating this data across these disparate sites. I can't remember what we have for medical. We have over 20 different electronic medical records in the system, and all kinds of other data pulls. And we foresee that going on, for the next 10 years before we can ever get to a unified electronic medical record. I think we just have too much money invested in all these separate systems that we have. So that's our data aggregation. For our metrics and performance measurement, this is just examples of stuff that we're tracking, but and I just pulled some of these, we call them cards, Out of our, this is our MSSP track 3, so this is all done with the claims data from Medicare insurance savings. That's what's working best for us right now. And we do report that, feel it's accurate enough to bonus doctors on, reward doctors on. So we can do our PMPMs on the first slide, and then if you look over to the right of that, I believe that shows our PMPMs by facility type. So we're breaking down the PMPMs into the different categories for acute care and physicians, and so we can look at it in any way we want, any kind of bucket we want that way. We're doing readmits per 1,000, looking at that on a regular basis. One of our biggest pushes is annual wellness visits. We figure if we get people in for annual wellness visits, we get their risk scores up, and then we also get their metrics for the G-Pro reporting done at the same time. And so our track 3 overall is, what does that say, 31% or 31% or thereabouts, so 38%. But that's because one of our markets is not doing too good. They're only at 20%. We have 2 other markets up above 50% now getting these done. And we have pockets where we're getting well over 70% of our patients getting annual wellness visits done. And we're feeding that back. We're now beginning the bonus doctors on their annual wellness visit rates. And we're seeing a steady rise in how we're doing on the annual wellness visit. One of the problems we ran into of our old database is if you ever wanted to change a measure, like my hemoglobin A1C less than 8, change it to less than 7.5, we'd have to submit the request to a governance committee. The governance committee would have to look at it, prioritize it, put it in the loop, the queue to get done. It would take us 6 months if we wanted to change the hemoglobin A1C value from 8 to 7.5. So we told our vendor, we'd like to be able to just go in there and do this. So they built that in, so now we can just go in, you click on the custom measure thing, the measures all come up, and you can go and find hemoglobin A1C, and down the bottom there, all I got to do is just click where the number is and change the value I want. So very simple to change our metrics if you want to change a metric. And in fact, even I can do it in about a minute, so don't have to even ask the data team. I wouldn't be able to do it myself, but I could. So we produce automated reports for our providers, so that they just pull out the data that we have, and this creates reports on a monthly basis. And we're trying to figure out how you distribute these to the providers is a big deal. We have this provider portal, so we have this website where providers can get, have the login information. They can do it on their phone or do it on their website. So these things feed automatically into this provider portal, but providers never use it. Our health coach uses it all the time. They go there if they want to pull down data, because not only do we have the provider report, but they have all their data behind it too. So each metric there, if the provider wants to know, which of my patients have their blood pressure control and which ones don't have their blood pressure control, it's just a click on there, and they can get the whole data set behind it. So they can confirm that the data is right, or they can work the population. Now they don't, but their nurses do. The health coaches in their office do look at that and pull it down from this. So then we started creating paper reports. We told the coaches, put it on their desk. Let's see if they'll look at it, if they'll do anything with that. Well, that didn't work either. And now, in two of our markets, we now have full-time staff. All they do is take the reports and go to doctors and meet them one-on-one to show them the reports or give them the reports. And we're spreading that to our other sites now. And I think just handing reports to doctors without a one-on-one, and not even a group conversation, a one-on-one conversation about their data and about what they can do to make their data better and why it's important is probably what you need to do to have an impact on these physician practices. Care management, so we built our transition coaching into this. So we have a protocol when patients are in the hospital, they're picked up by a hospital acute care manager, and they have certain responsibilities, and we automatically load the patients into their work queue every day. So we get the ADT files, load them into their work queue, so they get there in the morning. They can, I think I have that, I'll show that in a minute. They just go to their work queue, see their patients. They have to accept the patient, so we always know that they've accepted the patient, they take responsibility for that patient. They do their thing, and then when the patient gets discharged, they discharge it to an ambulatory care coach, and it automatically goes into that person's work queue, and then they have to accept that patient. So they accept that patient, the acute care coach is responsible for that patient. And they're responsible to get the phone call done within 2 working days and make sure an office visit is scheduled within 2 weeks of the time of the discharge. That's the bundle, that's all it is. We've had really good success with this, and we've had steady declines in our readmission rates. So we're at, we went up a little bit now, we're 14.5% for our overall readmission rate. But not bad. The national average is more like 17.5, and we're under 14, and now just a little backtracking. So anyhow, that's our bundle, this example of the work queues. So it comes up on their queue, and it has the patient's name. They click on it, takes them to the patient, and then the work they're supposed to do on that patient will populate for them automatically. I think I might have that. So kind of hard to see, but this is the discharge bundle. So when the coach accepts this bundle, it automatically populates, and the things they're supposed to do show up, and they have to go click off the, so it is a mandatory click off the things before you can move on to the next. But the other value of this is it not only standardizes it, they all do things the exact same way. I don't have it there later. We can measure and see how well we did. So when we first started doing this, we weren't doing the transition phone calls. You know, if you ask your care management staff, you know, do you do transition phone calls or discharge phone calls? They say, oh yeah, we do it on everybody. You know, and I've heard this for years. Oh yeah, we never miss transition discharge phone calls. No, you know, they did it on 40% of the patients. When we started measuring, and you know, we knew every single patient because we got it from the ADT files, and we documented whether they did it or not, 40%. And you know, and we're considerably better than that now in getting these things done. Once we get them through our care, our discharge process, we enter them into our high-risk strategies process. So we take our patients we think are high risk, and then we have another intervention we do for them. And it really is 6 visits weekly. And the place we use this most is after hospital discharge. This is our highest risk population. Anyone with 3 or more ED visits is a very ripe population. We find lots of interventions in that group that we can do stuff with. Anyone with a diagnosis of heart failure or COPD, we're working on it, and we've been real successful in reducing utilization in that group, but we're working on, or anyone with more than 2 chronic diseases. One thing we learned is working with our very sickest patients didn't work. We gave all of our health coaches their 10 sickest patients and said, here, work with these. And it turned out 40% of them were dead because our data was 4 months old by the time we gave it to them. You know, another good percentage of them were better. A good percentage of them were so far sick there's nothing you can really do to help them, so maybe get them in hospice care. And so there's very few people in that top 10 sickest for each coach by risk scores. So we just, you know, so we have capability of doing risk scores. I think I'll show you that. We'll just calculate the risk score and say, here's your 10 sickest patients. That didn't work too good. So we got to figure out, how do you look downstream? So we're looking at other things. One I want to look at is anyone on 5 or more medicines. You know, I think the people polypharmacy is a good area. Anyone who has 5 or more physicians they're seeing is probably another good area to work on. They can have a lot of coordination of care. We haven't gotten into these, but we're looking at, you know, that's the kind of things we're moving to. That's our high-risk protocol. Built it into the bundle, so they just have to follow exactly. They have to do all the different items that we have listed there during their 6 weeks with the patient. We work on gaps in care, so we can identify the gaps in our software, and so particularly working on getting people in for PCP visits who haven't had that done. Annual wellness visits, mammograms, diabetes, and blood pressure follow-up. Things that we can work on. We can generate these lists and then export them to the health coaches. We're just building the system now to automate that. So we'll get the list and we'll figure, okay, coaches can do 6 of these a day. We'll load 6 more into the queue each day, so they have that to get done. it just shows a report for annual wellness visits, so we can see how we're performing throughout the system. And then whenever you get the reports, just below that are all the patients behind it. And you can sort them by who had the test done, who didn't have the test done, and export it to the coaches. And now we're automating the process for all that. And then with all these coaches all over the place, you want to know what they're actually doing, and so we developed this care management report so we can look at it and see how many post-discharge phone calls did they make, what percentage of the discharges that they were assigned, did they get the phone call made, did they get the follow-up visit done. We like to measure how many initial face-to-face visits are done with patients. So that's a key to our program that you're going to see different than many others, is that our coaches are physically located in physician offices. So the initial visit with a patient, the next contact is face-to-face in the office. After that, they can do email, phone, but we always like to have some face-to-face contact with the patient. We can do ad hoc reports, and it's a really slick system for the ad hoc reports. We get this database that looks like this, and it has 250 columns. So all the data points we have there are there for each patient, and you can just go through here and pick out whatever columns you want to give. So one of the things I can filter is I can filter this by all patients in Central Iowa. So, and I can get, so if I want to get one market, their data, I go in here and I just filter by all patients in Central Iowa, very simple to do, and then I get that database, and then it goes into things like right here in Central Iowa, and I can just take that data file and hand it to the Central Iowa team, and then they can go and look at their data. If I wanted to add anything else to that, I want to look at all the hemoglobin A1Cs done in Central Iowa, I can grab that. All the patients with diabetes, whether or not they had a hemoglobin A1C, I can look at that. Very simple process. You don't need to be an SQL programmer to get SQL capabilities out of the system. GPRO reporting, we're doing GPRO reporting for 4 MSSPs. So this is a massive task for us to get this GPRO reporting done. It's built in here very nicely. So we get our lists from Medicare of all the patients and their metrics, loaded into our system, and then it automatically assigns measures to coaches, or depending on if they're responsible for that patient. So we know where clinics the coaches are in. So where the GPRO patient is in that clinic, the coach will get that assignment. And so they can go in here and they can click on a measure. So they click on the mammogram measure. All their patients in the mammogram measure will explode under that, and then they can just work through them, and they can click on whether they completed that measure or not. And then a cool feature of this is when you're in a patient, you can click on the you can click on that patient again, and you can get all the measures that patient is enrolled in. So when you're in a chart, you will be able to look at all the measures, so you don't have to do mammogram and then go back to that patient's chart for hypertension. When you're in the chart, everything's available. You know what you need for that patient. So pretty slick system for doing GPRO. In development, we're doing episodes of care, so bundles, so we can look at our joint bundles and things along that line. Network leakage is a big deal for us, and we're able to measure network leakage. We know where stuff is going. We don't know what to do about it yet. It appears that most of our leakage, like for joints, most of the leakage of our system for a doctor, they just had one. And so there's no clear pattern. I think it's patients just self-selecting on our system rather than that our physicians aren't really aligned with us to keep it in our system. Yeah, we think it's a big opportunity because 60%, we keep 60% of our business, 40% of our business leaks out of our network, and that's a big opportunity for us to work on that. We do risk scores, clinical documentation improvement, so we can evaluate we can determine the risk scores, and then we will we'll look at opportunities for like diabetes and complications, and see who's diagnosing just diabetes, who's diagnosing diabetes with complications. Go out and talk with those doctors. We can look at drop risk scores, things along that line. And then our interoperability we're working in. So in summary, our lessons learned from all this are, we think far and away the key thing you need in a data warehouse vendor is the ability to aggregate your data. You want to aggregate everything you can in one platform. You don't want to be looking in multiple places. We work with Humana, and they have a data platform we can get into. We work with our large commercial insurer, and they have another platform. We don't want that. We want everything in one platform that's ours, so everyone works off the same platform. Don't be fooled by analytics wizardry. We were once. They had wonderful analytic reports, but they couldn't get the data in there to do it. The other thing about analytic wizardry is you can't work on 100 things. You know, if you get 10 things you can do well, it's much better than 100 things that you really can't focus on. And then black boxes, you know, there's these predictors of whether you're going to be a hospital, risk of hospital admission predictors, and we you don't really know how they get to it. So we can now choose exactly how we want to determine the risk of hospital admission and develop our own algorithms and try them out and see how they work. You need to monitor data flow at the local level. What we learned before, we would not know that data stopped flowing from one source until we saw the metrics start going down. And then we looked 3 months later and said, well, it's because they quit sending us that data. So we now monitor on a daily basis. We know what should be coming in and how much data should be coming in from each source on a daily basis. And if it drops off, we know right away, and we can get right on it so that we don't find dropped data. I think care management platform, absolutely mandatory to be successful at this, ideally built right into your data platform. No vendor has a mature population health solution. This is all in flux as far as we're concerned. We've been doing it for 20 years and it's still all changing and not settled on the best way to do it. So you need to find a partner who's going to help you develop along with you. And then lastly, it took me a while to figure this out, that data is never perfect. There's always a problem with the data. So if you work with doctors, they're going to find that problem and tell you about that problem. And you have to get over that. And if we calculate some Medicare data based on our data warehouse, and Medicare calculates it, it is absolutely never going to be the same value. And it never will, because we have different time frames and different stuff excluded. And so, they just have to go with it. The data is not perfect. So that's our journey that we've had at Mercy ACO. I'll be happy to answer any questions if you have any questions.
I'm in Phoenix. Half the cars in my local Trader Joe's has an Iowa license plate. What do you do about that? They'll be heading back to Iowa soon. Spring trading is over. But they've been in Trader Joe's.
I'm going to be going there next week. And,
what do you do? How do you capture that data? Because clearly, Medicare, these people are mobile, and seriously, I'm joking to say half of mine, but there are a lot. Michigan, Dakota, and what have you. It's hard to capture them.
well, the only way we catch is from the Medicare claims data. So we get the claims no matter where the claims come from. So 4 months later, we know you've been there. We know what you did, but we don't know at that time. And it's built into the baseline. These patients have always been going there, and so it's built into our baseline. It doesn't cost us more that they're leaving, and so we haven't done anything to address that population. So if
You're coming out of spring training? You're coming to Arizona?
Yeah, I'm leaving tomorrow. Come back. I'm going to Scottsdale.
Good.
Yeah, just because it's warm, not because of spring training. This because it's warm and get away from Iowa.
And go.
Like a wouldn't. No. All right. Anything else? Okay, well, thank you.
All right, let's give him a big hand.